First I had TB, and TB put me down. And you know, once you are down, everything stops. Then from there, multiple complications, poverty, all that.
Across much of Africa, there is a plight of pain and suffering. Famine, war, civil unrest, disease. Many nations struggle to provide even the most basic support for their people. Uganda is one such nation. Since the fall of Idi Amin and a civil war, Uganda has struggled to provide adequate and affordable health care to its 32 million inhabitants. The average life expectancy is 54 years. In sub-Saharan Africa, more than 20 million people are living with HIV/AIDS, and there are over 15 million AIDS orphans. In Uganda, in the 1980s, 30% of the population were infected with the AIDS virus. Now, a rare success story in Africa, the number is closer to 6%. But still, over 60,000 people die of AIDS-related illness in Uganda every year. Cancer is also prevalent. In the country villages, there is only one doctor for 50,000 people.
There's only one cancer centre to serve over 30 million people, one trained oncologist, one radiotherapy machine.
Throughout Uganda, nearly 100,000 cancer patients need urgent access to basic pain control. Due to the lack of medical services, extreme poverty and poor education, tumours can disfigure, rupture and cause unimaginable pain. This film documents the scourge of cancer in Uganda and the devastating effects caused by the lack of treatment and pain control. With only one treatment centre in the capital, Kampala, chemotherapy and radiotherapy is unavailable to most. One hope for those suffering from cancer is work done by the hospice movement, in particular Anne Merriman and the organisation she helped to create. Hospice Africa Uganda has been building a unique palliative care service for the past 20 years.
When we work out the number of people in Uganda at the moment who need pain control at this moment, it's something like 200,000 people. Now, we have one doctor to 19,000, but in the villages it's 1 to 50,000. To them, cancer means pain and a terrible, terrible death.
Well, as medical doctors, we had a long-standing interest and involvement in palliative care. So when we retired from medical practice, we contacted Dr. Anne Merriman, who we had known was involved in this area of healthcare in Uganda. So when we went there and we worked with her service for a short period, and she suggested that we go down to Jinja because there were some local volunteers just starting a service there. We were very interested on her model of hospice care, and this really appealed to us. So when we went down to Jinja, we saw there was a huge unmet need for palliative care. The patients had no access to curative care. They didn't have, because they were so poor and they lacked transportation, they never got an opportunity of getting any surgery, chemotherapy or radiotherapy.
Once a small fishing village, the southeastern city of Jinja has benefited from being located on the trade routes between Kenya to the east and Uganda and Rwanda to the west. It lies beside the source of the River Nile, And locals say that it takes 4 months for one drop of water to meander the 6,695 kilometers north to Egypt and flow into the Mediterranean Sea. Outside of the city, in rural areas, people like these sugarcane farmers survive on subsistence farming and trading in local markets. The average household income is about €6 a month. Access to healthcare of any kind is difficult and mostly unaffordable. With this in mind, Hospice Jinja was founded in 2005 to meet the palliative care needs of patients with advanced cancer and HIV/AIDS.
Like the rest of other hospices in sub-Saharan Africa, we focus on cancer patients and also on the terminally ill HIV and AIDS patients. And right now, as we speak, 55% of our patients are cancer patients and the 45% are patients with HIV and AIDS.
The Jinja Hospice was started with the help of local and international fundraisers and supported by people like retired Irish doctors Frank and Patricia Hassett.
Well, our supporters and donors have achieved a lot over the years since 2006. A palliative care service is in place in Jinja, working with a dedicated local team, which includes 8 nurses, 5 of whom specially trained in palliative care. Patients and their families are seen at the centre in Jinja, and as the majority of patients are rural-based, outreach clinics and roadside clinics have been established, and we also do home visitations on the patients who are too ill to travel. So thanks to the generosity of our donors, we've been able to get 2 vehicles to see that there is regular medication for the patients and that the staff are paid on a regular basis. We also have an education program in place for the staff and for the community volunteers who work in the community and help identify the patients who are suitable for the service.
The size of the area the hospice covers is vast, so they have developed a unique system of community volunteers to help identify those who are in need. Once identified by the volunteers, hospice staff visit those who are too ill to attend the outreach centres in the rural villages.
Mr. Sulaiman Chinabi has been on the hospice program for the last 3 years. He was diagnosed with the cancer of the breast, and since then we have been taking care of him. By the time we met him, the disease was already advanced, and the best way was to palliate his symptoms and challenges that we were going through. I'm asking him to tell us how he is today. So the bleeding is controlled from the tumor, but it produces some fluid. Number 2.
That ever since hospice started treating him, they really help us. They give him good treatment. When sometimes Mzee can be there crying, saying that I'm feeling pain, but the treatment, it's very good.
So when asked about his pain, he says his pain when he takes the oral morphine is controlled, since he does it 5 times a day, and he was explaining to us how he does the 5 times. When we met him, the tumor wasn't as big as that, but as we say that the cancer is continuing to grow. But in the first case, his major problems were pain and a foul smell that he was getting from the tumor.
Okuunanga wena mpigana buli kukulira ngera bwobawo no bulido singa no liku singa ni ndo ojikole
When asked about the foul smell from the tumor, he says, if it were smelling, every one of us would have been. So, but it's not there, and so it is also well controlled.
We call them family members. The way how they treat us, the way how they take us. They don't take us like people who are maybe patients. They take us like family members.
Unlike Hospice Kampala, the local government imports the morphine powder. Due to inefficient administration, the teams face running out of morphine on a regular basis. The doses are carefully rationed, which can frequently result in patients running out and suffering extreme pain for days.
One of the problems that people on the ground face is the supply line. Sometimes money is available to purchase drugs when there are no drugs. Sometimes the drugs are available and there's no money. And the consequences are very, very bad for patients who can suffer immeasurably when the drug is just not available on a given day.
Florence Nandogo is 46 and has been diagnosed with a nasopharyngeal cancer.
When she had the oral morphine that we gave her the last week, the pain was controlled and she was able to eat some food. But now, 2 days, the oral morphine ran short. She no longer has it, and so the pain is back in full swing. So we straight off give her a dose of oral morphine to help her to kill the pain straight off. No, it's okay. They are asking her about the nose bleeding, and she is reporting and saying that after we met her last week, after that time, the bleeding became very severe, and it was too much that she thought maybe she was going to die then. And thank God it's later reduced on its own. And now she's having kind of bleeding still, but like the normal that she usually experiences, a little bit just. The levels of prognosis are also determined by what other treatment options you take up. So assuming maybe she had had a radiotherapy, as she was suggested 1 year ago, maybe she would be a little bit better. So it seems she doesn't have a lot of time left.
For most of the people that the hospice cares for, radiotherapy and chemotherapy in Kampala is geographically and financially out of reach. Eventually they die, leaving family and friends behind.
After a person dies, the remaining family are bereaving and grieving the loss of their loved one, and it's really important that they receive support. And that has always been a feature of palliative care, and it's equally a feature of palliative care in Uganda. So typically after somebody dies, the team will go out and visit a few days after the funeral to offer their condolences to the family. And it's really a way of sharing their loss. And people find it very supportive. And again, I think find it really helpful that team would take the time to come to them. I think it helps them to feel that the person who's died was very valued by the team and that they themselves are valued by the team. And they derive a lot of support from that.
This is what we call a bereavement visit. We come and share a moment with the family, and we ask how the patient was before he or she passed away. And we also bring in our condolences as hospice and the team. And so we came along with other patients, and so they can also be able to sympathize with the rest of the family.
It's a particular marked problem in Africa. The average consumption per person per year across the African region, is 18 times lower than the world average.
Afsa, she's a 39-year-old lady. She was married and she separated with her husband. She has 5 children. Since she fell sick, they have never come to see her. I think Afsa wants to see her children and her children want to see the mother, but the father has refused to let the children come to visit her. You see, she's really very sick, but she's hanging on. Maybe she really wants to see her children. Sorry.
Hi, Mama. Ora never went to Yana. No can look to
Nangichi, Nessa Catigua, Napulumatinga, Tainakari.
Stejo. Samanana. What? Can't wait to meet you.
The World Health Organization has made it clear that morphine is an essential drug for cancer pain relief. What we see in Africa, as in many other parts of the world, is that many problems and barriers in getting access to morphine. Although it's a cheap drug, it's easy to produce, and it's relatively easy to administer in trained hands. At the moment, many people who would benefit from it are not receiving it. Uganda has demonstrated superbly that you can overcome these problems, that you can prescribe morphine, you can make it available to those who need it without it being stolen, without it being diverted into the wrong hands. It provides reassurance that this can be done in countries with very small resources otherwise.
In the future, we hope to extend the service to the rest of the Busoga region. We also hope to continue with the educational component of our service to train the nurses involved in the service and also to train the community volunteers in the community that identify the patients that are suited to the service.
The World Health Organization says that chemotherapy and radiotherapy won't be available in Africa for generations.
There is hope. One of the really exciting things that's happening at the moment is the idea that we can start to think about freedom from pain and access to pain medication as a fundamental human right. A number of lawyers, philosophers, activists of various kinds are working towards building up a case for the recognition that freedom from pain and access to pain medication is a human right. This is a much more powerful argument than we've ever had before, and it's getting listened to in places where palliative care was previously ignored.